Hello, my name is Dr. Dewan S. Raja. Today I will discuss about hyperaldosteronism. These are a group of diseases or conditions characterized by chronic excess aldosterone secretion. Hyperaldosteronism may be primary or secondary to an extra-adrenal cause. We know that aldosterone is secreted from the adrenal cortex, from the zona glomerulosa. But we may have some secondary causes, that is from extra-adrenal cause. Primary hyperaldosteronism is characterized by autonomous overproduction of aldosterone with resultant hypertension, high blood pressure, especially systolic blood pressure, suppression of renin-angiotensin system, decrease plasma renin activity. Causes of primary hyperaldosteronism: bilateral idiopathic, most common. Idiopathic bilateral, there will be enlargement of the adrenal cortex, adrenocortical neoplasm, around 35% cases. Bilateral idiopathic enlargement of the adrenal gland is more common. It is about 60% of cases of primary hyperaldosteronism. A solitary tumor or neoplasm, usually benign, rarely malignant, around 35% cases. It's also called Cone syndrome. Lot of books actually say all the primary hyperaldosteronism as Cone syndrome. Okay, many books say that way. But we accept adrenocortical neoplasm is the Cone syndrome. Okay, around 5% cases, the hyperaldosteronism is familial. Okay, so if you go there, primary hyperaldosteronism, most common, idiopathic hyperaldosteronism. So an adrenal gland is large, the adrenal cortex is large here. This is the cortex, this is the medulla. Usually aldosterone is released from the zona glomerulosa. Second most common cause is adenoma tumor here. It may be malignant on rare occasion that will release the hormone aldosterone. Aldosterone is coming from here too. Here, very rare, around 5% cases, glucocorticoid suppressive condition. There will be stimulation of the ACTase from the anterior pituitary that will increase the size of the adrenal cortex, hybrid glomerular cell responsive to ACTH. This is the only one type, is rare type. This is adrenocorticotropic hormone dependent. Okay, so it is a rare cause and it can be suppressed by glucocorticoid like that of the dexamethasone. Okay, aldosterone high, what will happen? Sodium, potassium absorption will be altered. Sodium will be absorbed, potassium will be released. Potassium is releasing here. Sodium is reabsorbed from tubular urine back to the bloodstream. Sodium don't go alone, it go along with water, so there will be excessive body water, extracellular fluid volume that will happen. Potassium move from the bloodstream into the tubule and is excreted, so patient will suffer from hypokalemia. Also they will lose the hydrogen so in the urine, so there will be addition of bicarbonate to the bloodstream, so that may lead to metabolic alkalosis. Sodium is reabsorbed from the tubular urine back to the bloodstream. Okay, these are the major causes of primary hyperaldosteronism and the effects on kidney. Okay, here hyperaldosteronism, secondary hyperaldosteronism, aldosterone released in response to activation of the renin-angiotensin system. It is characterized by increased level of plasma renin. So plasma renin is low in primary hyperaldosteronism. It is high in in secondary hyperaldosteronism. Okay, what are the causes or scenarios for secondary hyperaldosteronism? Decreased renal perfusion like arteriolar nephrosclerosis, renal artery stenosis, arterial hypovolemia, and edema, congestive heart failure, cirrhosis of liver, and nephrotic syndrome. Pregnancy-related hyperaldosteronism due to estrogen-induced increase in plasma renin substrate. Okay, so clinical features of hyperaldosteronism. Hypertension. Hyperaldosteronism is the most common cause of secondary hypertension, although the aldosterone effects on the mineralocorticoid receptor through the aldosterone effect on the mineralocorticoid receptor, reabsorption of sodium, increased reabsorption of water, increased extracellular fluid volume, and elevated cardiac output. This patient also may have polydipsia and polyuria due to high blood pressure. Excessive glomerular filtration rate may increases the output of urine that may lead to polyuria. Okay. Cardiovascular compromise like left ventricular hypertrophy, decreased diastolic diastolic volume, and increased prevalence of stroke, that is cerebrovascular accident and myocardial infarction. Hypokalemia manifested as weakness, paresthesia, visual disturbance, and occasionally frank tetany. These are the manifestation of hypokalemia. There will be metabolic alkalosis because hydrogen is released along with the urine through the renal tubule. Bicarbonate is absorbed to the body, so there will be metabolic alkalosis because it is also handled by the kidney, and this is the condition of metabolic alkalosis. Diagnostic workup and imaging. CT, MRI, adrenal vein sampling, and serum electrolyte study. 24-hour urine test for aldosterone and potassium level. Captopril test and renin and the aldosterone stimulation test. Treatment of primary hyperaldosteronism. Control of blood pressure and hypokalemia. Spironolactone, a diuretic, it works against the aldosterone, and it is synthetic. It is made of synthetic steroid. Another drug is iplerenone. This is a mineralocorticoid receptor antagonist. These two are the drug for primary hyperaldosteronism. Treatment of secondary. Okay, so this is treatment of primary hyperaldosteronism, control of blood pressure, hypokalemia, spironolactone, iplerenone, a mineralocorticoid receptor antagonist. Okay, there is an antagonist. Okay, so surgery may be required if you have one unilateral adrenal cortical tumor, then it should be removed surgically if it is feasible. Usually it is less than 2 centimeters. Treatment of secondary hyperaldosteronism. Treatment according to the cause like cirrhosis of liver. Okay, so it should be managed accordingly. But in secondary hyperaldosteronism, the spironolactone is also useful in secondary hyperaldosteronism. And that's all about our presentation on the hyperaldosteronism. If you have any question, please feel free to ask me. Please share the information with your friends. Please support my channel. Please subscribe me. Have a nice, wonderful, and blessed day. Bye now.